so much. Okay. Okay, so for those who are coming in for the first time, I don't know whether there's anyone who is coming in for the first time, but anyways, usually we try to do this once every month or two. Yeah, not super frequent, but frequent enough. Every time there is a theme, but this today is SVT. The theme is about SVT. So a couple of the slides that I will show today are repeated from before, but has been a while, and we did not record that session, so that is why I'm repeating those slides. Okay. Okay. So let's start. Okay, guys. So yeah, and just to remind you, there is our YouTube channel for those who are interested. And I suggest people try to every once in a while review them, because it's very relevant to us at least. Okay. Okay, so we will try to classify SVTs and introduce terminologies, and then we'll show a couple of ECG examples that are suggestive of a specific SVT type. Okay. Okay, so like we said before, SVT is classified into reentry or focal automatic. This is clinical classification. And for us clinicians, this is the most relevant classification. And reentry is the main. The most common mechanism of SVT in general. And for reentry to occur, you need to have two pathways. Okay, so for example, pathway A and pathway B that are connected proximally and distally to each other, and there is tissue of no conduction between them, and those pathways usually do have different refractory periods, and one pathway conducts slower than the other, and that pathway that conducts slower than the other has shorter refractory period. To simplify it, for example, this is your sinus node. Say a patient has an accessory pathway. You see my pointer? Let me just use laser, I guess. You see my pointer, right? So that's your sinus node. You have a patient with an accessory pathway and an AV node. So two pathways that are connecting the atria to the ventricles, okay? So, and the patient, there is a perfectly timed PAC, premature atrial beat, such that it blocks down the accessory pathway, because again, the accessory pathway often has a longish refractory period. So it tend to block down the accessory pathway. However, the AV node has a shorter refractory period, so that PAC will conduct down the AV node. And like we all know, the AV node has a slow or decremental properties. And if the conduction down the AV node gets slow enough, it might allow for the conduction to travel downwards. And because it was so slow to travel downwards, it might that accessory pathway might have enough time to recover from that PAC and conduct the electrical activation or conduction backwards. And then you have a re-entry. So down the AV node slowly, such that the accessory pathway recovers and the conduction travels backwards across the accessory pathway. Make sense, guys? We had discussed this before, right? Questions? Okay. Yes? Okay.
Yes.
Okay. So often starts with a PAC, like appropriately timed PAC, and then it starts the circuit, okay? And then also it often terminates by a PAC such that it collides with the re-entry, and then the re-entry stops, okay? Okay, so let me show you that ECG from a Holter of ours. Any volunteer? It's an easy ECG. Can anyone volunteer to try to read that ECG or that Holter, please? Tracing, really quick. Easy. يلا اسماعيل.
يا أستاذ محمد، السلام عليكم.
يا سلام، سهل.
احنا جايين بعد الاو بي دي خلصانين.
I know. الله يعطيك العافية.
الله يخليك.
يلا tell me.
ماشي، هو كان الأول كان ساينس ريزم.
Hello.
start first as a sinus rhythm.
Yes. So
There is P
PQRS.
waves.
Right.
بعد كده start to develop بقى tachycardia. SVT البي ويف disappear.
Hello. Excellent. So PQRST, 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 a little bit of sinus bradycardia or sinus arrhythmia, PQRST, and then something fast starts, right? Before that,
Yes.
something fast starts, you see P that is different than the sinus P, right?
Yes.
This is your sinus P, and this is your different P, right? So there's a P that came in a little bit early, there is probably at a 600 or 500 milliseconds.
Different focus, from different focus.
Right. So this is, your PAC. This is your probably PAC that started the tachycardia, okay? If you know that PAC started the tachycardia with a long PR, right? You see? So the patient PR interval is usually this, it's usually short, right? Around 80 milliseconds. But this is definitely starts, the PR is definitely beyond 200 milliseconds, right? And then the tachycardia starts and you don't see P waves. Excellent. So when you don't see P waves, and then it's a narrow, complex, usual QRS tachycardia, so it's an SVT. And then when you don't see a P wave, what do we call this SVT? Remember, we discussed this before, short RP. Remember, short RP SVT or long RP SVT, remember? Remember, Smile? Well, I forgot. I will remind you guys in a second here, but this is a short RP SVT that starts with a PAC with a long PR interval. So why am I stressing long PR and short RP? Because this is typical of AV and RT. So you have a PAC that blocks in the fast pathway, goes down the slow pathway, and then tachycardia starts with a short RP. Why is this? Because because by the way, this is a nice basic EP book by Richard Fogoris, if you want to check it out. But anyways, so that's a diagram from this book. So this is the AV node complex, okay? There is a slow pathway component within the AV node, and there's a fast pathway component within the AV node, okay? So you get, and then during sinus rhythm, the fast component of the AV node conducts, and then you have normal PR, okay? If you have a perfectly timed PAC, for example, in diagram C, so PAC comes in, blocks down the fast component because it has a longer refractory period compared to the slow component. So it blocks down here, it goes down the slow pathway, okay, and goes down the QRS or down the AV node, but also travels retrograde. And if it's slow enough, that fast pathway component of the AV node might be ready to accept that retrograde conduction and conduct it backward. And then this goes down the slow pathway because the slow pathway has a short refractory period. So it accepts conduction, easily, and then travels down, goes to the AV node and backward up the fast pathway. So you have a circuit within the AV node, okay? So you have a PAC, starts with a long PR because it blocks down the fast, goes down the slow. So that's why you have a PR prolongation. And then you have short RP because the QRS fires and then retrograde A goes up the fast pathway so that, by the time the QRS finishes, the P already conducts. Okay, makes sense, guys? So let me draw it for you. Yeah, it's a little bit complex here, but if you draw it, if you imagine it will be easy. So the QRS goes, the QRS starts and the P starts at the same time because it goes up the fast pathway, okay? So by the time the QRS finishes, the P already conducted. So you have short RP tachycardia, or you have a P wave that is hidden within the QRS complex, okay? So if you see a PAC, long PR, and then short RP tachycardia, that's suggestive of AV NRT SVT. Okay, guys?
Yes.
And this is typical AV NRT. Okay, so this is a patient of ours. This is 7 years old who had tachycardia since birth. I reviewed his file. He never had, sinus rhythm. Okay, he always was in tachycardia, but not super fast, like not 250 beats per minute. It was, around 180, 190, 200, 170, 160, and so forth. Okay, so he was initially on a beta blocker and flecainide. This was like 7 years ago, 6 years ago. However, recently, maybe 2 years ago, his heart rate started to come down to 160, 155, 160, and people thought that he was in sinus rhythm with a little bit of, sinus tachycardia. So the meds were stopped, and he showed up to the ER one day with palpitations. Okay, and that's his ECG at the time, which again was very similar to his initial ECGs, except the heart rate was a little bit faster. Okay, here 170, the heart rate was 174. Okay, so another volunteer who is happy, please, to who wants to volunteer this ECG, to read this ECG, please. There are people that I don't know. مثلا Ali or Ramadan. Are you guys? Ali, are you from where? I don't know who's.
أنا دكتور مساء الخير. حياك الله.
Saudi Arabia?
من السعودية صحيح. From
okay, good.
Differential General Hospital in الأحساء. حياك الله.
Welcome. So Ali, do you mind? Do you want to review? Do you want to read the ECG? It's an easy one.
Sure. I would like to contribute. Yeah. It looks like 12 lead rhythm ECG.
Okay.
With it looks regular.
Okay.
And the short QRS. I see
narrow
B
QRS.
waves.
Yeah.
Narrow, narrow QRS complex. There are B waves. It looks like a rate of 170.
Yeah.
And it looks like long RB. The B wave is just before the QRS complex. So it looks like a long RB.
Okay, excellent. So there is a narrow, complex, regular tachycardia with long RP, narrow, complex tachycardia, right?
Yes.
Is it sinus tachycardia or not? Because this is one
it
of
doesn't look like coming the axis for the B wave. Can see it here in 2. It looks negative.
Yeah.
AVF also looks negative, so it's coming from downward. It's not coming from this inward.
Yes, excellent. So it's not sinus tachycardia. We did this mistake at our center. So people thought was maybe sinus tachycardia and they stopped the meds. So in fact, yes, like you said, it's long RP tachycardia. It's not sinus tachycardia. And it's superiorly, the vector is superior, coming from the inferior part of the atrium. Luckily his function was never depressed, maybe slightly depressed, because the rates were probably not super fast. Plus he was controlled decently until 2 years back. So anyway, perfect. So this is, in other words, one of your differential for long RP tachycardia is PG. You heard of PGRT, right?
Yeah, PGRT. It's more deep than this, isn't it? It's not very deep. I don't know.
This is very, it's it's like a, like a flutter wave that is not very fast. PGRT P wave is very wide. It looks like flutter, but not very fast, because it's coming, it exits from where the flutter also exits as well. So it's very resembles the wide, it's a wide P wave. Okay. Anyway, so it's one of your differential. It's
exactly.
What suggests, why is it most likely PGRT? Because it's not very fast and it's very regular and it's incessant. Okay. And then in the EP lab, there was, it's typically by the posterior CS area. So it was indeed there. And this, the white The white color is where the accessory pathway was sitting, and this is the CS. Okay, so it was very near to the CS, and this is the his. Okay, anyways, so like we said, the differential diagnosis for long RP. Sorry, we didn't say that, but the differential diagnosis for long RP is sinus tachycardia.
Sinus tachycardia, atrial tachycardia, flutter.
Well, flutter is
ectopic.
Yeah, so I would say, you know, long RP tachycardia, differential, which 1-to-1 is atrial tachycardia, PGRT, atypical AVNRT, and sinus
Atypical AVNRT, yes.
Okay, so excellent. You know, when you see long RP tachycardia, obviously, you know, the definition of long RP is the P wave starts beyond 50% of the RR interval. Okay. And this is clear. This is our same patient. Clearly, the P wave starts beyond the 50% of the RR interval, which is probably somewhere here. Okay. Okay. You know, PGRT and AVNRT might look similar, but again, PGRT is typically slow tachycardia, incessant, and atrial tachycardia is not reentry. So, you know, you might not. You know, it's typically not classical reentry. It behaves not like a reentrant rhythm. And then adenosine, if you give adenosine and doesn't convert, then maybe it's atrial tachycardia because it's not adenosine, you know, sensitive. Okay. So PGRT. So for people who doesn't know what's PGRT, PGRT just means that there is an accessory pathway that conducts retrograde. So this is your AV node. That's the accessory pathway, conducts retrograde. Okay, and slow. Okay, so it only conducts retrograde and conducts slowly. Okay, such that the tachycardia goes down here, the AV node. So you have a QRS. Okay, and then by the time the atria activate, it gets activated late because that accessory pathway conducts backwards late. Okay, okay, guys. So you have, you know, so you have your. This is your late pathway. So it goes down the QRS and then very late up the pathway. So then you have QRS and then distance and then your retrograde P wave. Okay, guys? Okay. So that tachycardia is often difficult to treat because it's very incessant. Okay, drugs are helpful and you know, helpful of course, but they might not. Like in this case, he was never in sinus rhythm on drugs. Okay, drugs might just help with the rate, but rhythm control would be difficult with drugs only. Okay. Okay. Anyway, so he was ablated and he was discharged from our service. Okay. Okay. So this is another case. A little bit more difficult. Arij, I guess you are also from Saudi Arabia. Am I correct? Maybe, I don't know whether. Or Dalia. Any volunteers, guys? This is a little bit more difficult ECG and it's a little bit faint. So I will help you here. So this is 6 years old. Okay. Also our patient who had wide complex tachycardia since infancy. Okay. And that wide complex tachycardia always breaks with adenosine and it's regular, looks reentrant. Okay. So again, with reentry SVT, it's very regular. Okay. So there is regular tachycardia that is always wide and breaks with adenosine. Okay. Since infancy. Okay. So that's his ECG during sinus rhythm. And that's his ECG during tachycardia. I will help you here because very faint. So I apologize. It's an old ECG. You know, there is, you know, this is a baby ECG. You know, this is, you know, when he was infant. So that's a wide QRS for a baby at the time with left bundle branch morphology. You see positive QRS in V6 and left axis deviation. Okay. So left bundle branch morphology, QRS breaks with adenosine, and that's his ECG. Any takers? Arij or Dalia or anyone? Okay. Sumaya, can you speak? Then no one was
actually it's not clear.
Not clear. I will help you here. So PQRST, okay, PQRST, right? So sinus, And then just I will, that there is something between the P and the QRS. What is it?
Delta wave.
Yes, excellent. So if you see this, at least lead one looks like there is WW, but the PR is not very short. Okay, so it's a 20 WW ECG plus, and then I tell you the patient always has wide complex tachycardia that breaks with adenosine. What comes in mind? This is a difficult one. So
He had a underlying right bundle branch block from the start.
well, not the key. No, he has narrow QRS during sinus rhythm. So we had mentioned this before briefly. So there is something called, if anyone knows, he can shout out, please. But if you remember, there is something called antidromic SVT, remember? So you have an accessory pathway, okay? The SVT goes down the AV node, up the pathway. This is called orthodromic SVT, and it's a narrow complex tachycardia because it's going down the AV node, okay? However, rarely the SVT goes down the accessory pathway, up the AV node, okay? So you get wide QRS because going down the AV node, the accessory pathway, okay? So you get wide QRS that it looks like a wide delta, because it's going where the delta inserts, going there. So it looks like the delta wave, except it's a wide QRS, okay? So it's a wide QRS, regular wide QRS that breaks with adenosine, okay? And the patient has WW, he has WW, he has WW, and then he goes to wide complex tachycardia that breaks with adenosine, meaning the AV node is part of it. So you always have to think it's an antidromic SVT, meaning an SVT that is unusual, going down the AV node, down the accessory pathway, up the AV node. Okay, Sumaya?
Yeah, but what the accessory pathway is the fast pathway, yeah? Why it's
well, yes.
Why
so sometimes typically the accessory path, the AV node blocks, the accessory pathway blocks before the AV node, but sometimes it doesn't. Sometimes the other way around. Okay. Okay. So that's why this is rare. Orthodromic is way more often. Okay. Okay. So and I will discuss the antidromic SVT in a little bit as well more. So when you have reentry, so again we said SVT is classified into reentry and focal. When you have reentrant, there is further subclassification. You can subclassify the reentry SVT into macro reentry and micro reentry. Okay, macro, big reentry, micro, minimal reentry. Okay, so macro reentry is our typical WW, AVRT, or accessory pathways. Okay, so you have a reentry between the AV node and an accessory pathway, which are often there is a good space between them, and it's a macro reentry. Okay. Okay, so when you have an accessory pathway, SVT, your RP interval is by definition has to be more than 50 milliseconds, and in adults it has to be more than 70 milliseconds. So the RP, so that's why it's nice to know your RP duration. If your RP duration is very short, then meaning below 50 milliseconds in babies and 70 milliseconds in teenagers, then this can't be an accessory pathway mediated tachycardia. Okay, that's why I stress RP interval short or long. Okay, it's not just to torture people, it's just because it means something to us. Okay, so so your typical macro entry is your WW or concealed accessory pathway. We said before, what is the difference between concealed accessory pathway and WW? Do you guys remember what's the difference? Anyone?
The direction of the pathway.
Direction, صح. So WW, by definition, it has to conduct antegrade.
Yeah.
Concealed only conducts retrograde. Okay. Why is that important? Because the antegrade conduction is the dangerous conduction. If you have rapid AFib, which by definition is usually, AFib is rapid, that accessory pathway might conduct the AFib impulses rapidly into the ventricles, and then the patient might be in trouble. Okay, versus the AV node blocks the rapid AFib activity, okay? So when you have WW, there is a life-threatening risk for the patient. If you have concealed accessory pathway, it's usually just SVT. Yes, it's not life-threatening, but it might be bothersome, okay? Unless it's dangerous if it persists for many hours and days, but otherwise it's not acutely life-threatening, okay? Okay. So we discussed PGRT, which is form of long RP tachycardia. It's usually incessant. It's concealed, meaning the accessory pathway only conducts retrograde. It's slow or has decrement, other way of saying slow. And because of where it usually inserts, it has negative P waves in the inferior and left lateral leads, okay? So it's a posterior septal insertion typically, okay? Okay. Last example of QRS that we just saw, that patient has something called Maheim. And Maheim is just a fancy way of saying there is an accessory pathway that conducts antegrade only. It's opposite of PGRT. We said PGRT is a slow retrograde conduction, right? Maheim is a slow antegrade conduction only, okay? It usually, often inserts into the right ventricle, not the left side, the right side, okay? So because it's only antegrade, so the SVT during Maheim has to be antidromic SVT, right, guys? Make sense, Sumaya?
Yeah.
Yeah. So if you have a patient who always has antidromic SVT, then you wonder whether he's one of those Maheim tachycardias, because like we said, often the SVT is orthodromic, not antidromic. So if you have a patient who always has antidromic SVT, then you have to think of Maheim, okay? And then Maheim tachycardia is, people subdivide them into, we're getting more complex here, but just means that those fibers could be between the AV node and the right bundle, or right bundle and right bundle, like between the right bundle, or between the AV node and the right bundle, or between the atria and the right bundle, okay? And this is because it's an atria into right bundle, and so it bypasses your AV node. Sorry, this is the bypass tract that might cause people trouble, because again, it's a bypass from the AV node. If you have an AFib, that bypass tract might conduct rapidly into the ventricle. However, because it's a slowly conducting accessory pathway, the patient is often still protected from rapid conduction, but there are case reports of people who have cardiac arrest from Maheim tachycardia. Okay, rare, but it is possible as well. But typically, it's a slowly conducting accessory pathway, such that the tachycardia is not very fast, or if the patient goes into AFib, most likely the ventricular rate would not be very, very fast, okay? But again, there are case reports that suggest otherwise, okay? And our patient, at least when he was a newborn, he was able to conduct up to 290 beats per minute. So it was really fast for that baby, okay? Okay, questions for Maheim? So just to re-emphasize Maheim, so this is your typical accessory pathway. It's between the atria and the ventricle, okay? Your Maheim are between the atria and the right bundle, like this guy, or between the AV node and the right bundle, or between the node and the ventricle, okay? Maheim, he described the nodoventricular pathways only, but then later, people discovered fascicular ventricular and atriofascicular pathways, and they are all collectively now, called Maheim tachycardia. Okay, because the accessory pathway in Maheim, which is the atria to the right bundle, it's a slowly conducting. You have a subtle delta, okay? So you have a normal PR or normalish PR and a subtle delta, okay? That's why the ECG might not be very obvious for those patients. Okay, Sumaya?
Yes.
Questions, guys? I know Maheim is a little bit tricky, so questions? Anyone? No? Okay.
So we can say that patient is Mahaim
Yeah.
tachycardia
Yeah.
because wide complex.
Yeah. And he went to the EP lab. So we confirmed the diagnosis. Okay. So then with Microreentry, just really quick for Mahaim, why do we specify Mahaim as a subtype? Because the ablation of it is more tricky. The behavior is different than your typical SVT. Okay. So that's why it's a separate entity. Okay. Okay. So Microreentry, flutter and intra-atrial tachycardia is also Microreentry, but it involves the one chamber, which is the atria. Those involve two chambers, the A and the V. Okay. Okay. Anyways, we all know flutter. Flutter is just a re-entry that is traveling around the tricuspid valve. This is your tricuspid valve here. Okay. And then this is your CS here. Okay. So it's just if you follow the white, the white is your electrical activation. So it's just it's a circuit around the tricuspid valve. Okay. Okay. Microreentry, your typical example is AV and RT because it's a re-entry within the AV node complex. Okay. So it's a microreentry. There is something called sinus node re-entry tachycardia. Again, it's a re-entry within the sinus node. It's very rare. And it's often benign. Okay. Okay. So, and we already discussed AV and RT before. Okay. Okay. And I will not discuss AFib here. Okay. So, so this is your typical accessory pathway. So there's an accessory pathway or there's a communication between the atria and the ventricle, okay, outside the bundles of the right ventricle or the left ventricle, okay, or left bundle, right bundle. Okay, and then these are examples of accessory pathways in the left chamber here, and then an accessory pathway in the mid-septum, okay? Okay, so I was going to ask this question, but I already showed the answer. So the other classification of SVT is automatic. Okay, so examples are atrial ectopic tachycardia, junctional ectopic tachycardia, or multifocal atrial tachycardia. Okay, guys. Atrial tachycardia could be paroxysmal or incessant, so it might be very difficult to treat. Jet is usually post-op or congenital, okay? And we have many examples of both in our center. Okay, so that's another patient of ours. She is actually 5 years old with such an irregular rhythm, okay? So volunteers, easy ECG, guys. Speak up, please. Yalla, Doctora, anyone? Mitwali, you wanted, since people are shy. Yeah.
Yes. I see like it's irregular, but it takes a pattern like
Yes.
4 beats, tachycardia, and then pause. Also, the relation between the QRS and the B waves are not. And BB interval are regular, but is not fixed. The PR interval, I think.
The PR interval is not fixed. Maybe, yeah, probably.
Or
Yeah, I agree. Definitely
like
not.
retrograde B, maybe.
Okay, so we don't know whether it's retrograde P or antegrade.
Long,
we don't know, but it's definitely a long RP tachycardia, صح?
Yes.
Okay. So like we said, remember long RP tachycardia, we said we have the differential, right? So ask yourself, is it sinus tachycardia? Yes or no?
No.
No.
No. Hello. Is it PGRT? Yes or no?
So we want to see the axis of the B wave.
Yes. Excellent. So is it suggestive of a PGRT axis?
I think no, it is not
No.
inverted.
Hello. So it's not PGRT.
Mm.
AVNRT, slow AVNRT. Also, you would expect the axis to be going superior, so reverse. Okay. So likely not typical, atypical AVNRT. So you're left with what? Atrial tachycardia, صح?
Yes.
Yes. Atrial tachycardia,
Yes.
like we said, is focal, so it's typically irregular. It comes on and off, switches on, switches off, and the P wave axis will give you a hint. Okay, so that's a tachycardia that starts briefly and stops, starts, stops, starts, stops. Okay, and it's you know, if you see this patient Holter, she is almost always in tachycardia, but not super fast. Okay, and the function is slightly depressed, but you know, maybe 55%, 52%, you know, like this. Okay, so if you believe this is your sinus P wave, it's probably this is your sinus P waves, you know, positive in lead 1, positive in lead 2, positive in lead 3, and positive in AVF. Okay, so it's probably sinus P wave, right? And then so that's your sinus P wave, and then a burst of tachycardia that afterwards with the usual QRS. So it's a narrow complex tachycardia that starts with a P and ends with a QRS, right? That P that starts with tachycardia is different than your sinus P. Yes, the axis of it might, you know, so the lead 1 is very, you know, flat, but definitely lead 2 is positive, lead 3 is positive, and lead AVF is also positive, right? But the lead 1, the only difference, lead 1 is flat, and the morphology, yes, the axis is the same, but definitely looks different. You know, it looks less wide, more peaked and less wide compared to sinus P wave, right? Yes?
Yes.
Okay, so when you see such an ECG, you know, with time, you get, you know, there is something called pattern recognition, you know, with ECGs. You get to, when you see enough atrial tachycardias, enough PGRTs, enough sinus tachycardias, enough, you know, AVNRTs, at some point you need 1 second and you'll figure it out, you know. So such pattern where it's bursty and slightly irregular, and the P wave axis suggestive of not PGRT or atypical AVNRT, then this is tachycardia until proven otherwise. Okay, the fact that the fact that it's, you know, slightly irregular and bursty, this is suggestive of focal mechanism rather than reentrant mechanism. Again, reentrant mechanism is usually very stable. Okay, usually, of course, there are exceptions to everything. So this is an example of an atrial ectopic tachycardia that you know, with a P wave that is slightly different than the sinus P wave. Okay, so this patient went to the cath lab, and luckily she was in it during the anesthesia because she's only 5. And this is, so again, just to orient you, this is your CS, this is your patient looking up front. Okay, so that's your SVC, and tachycardia is starting from up top here. Okay, so roughly where the sinus node is located. Okay, so maybe just slightly above the sinus node, and because of the and this is your His, the yellow dot is your His. Okay, so because, you know, one of your differential would be left-sided pulmonary veins focused, because the pulmonary veins are sitting just posterior to this SVC, like you guys know by echo. So we went to the left side just to make sure it's not coming from the left-sided from the pulmonary veins on the left side. Okay, but it was not. So it was indeed in the right atrium. And so this is which makes sense because the focus of the tachycardia was as if it was, you know, as very similar to the sinus axis or sinus vector. Okay, guys. Okay, so another patient, 5 years old, who has such an irregular rhythm since birth. Not super fast, but you know, I think he is already on meds at the time of the CCG, so that's why the rate is not super fast, but it was a little bit faster than this off meds. Okay, so really quick, what strikes you on the CCG? Something that, you know, strikes you really really quick.
short BR interval.
Okay, short PR interval. And anything, what comes in mind when you
start with P wave?
Okay, I'm not sure who said short PR interval, but
this patient has congenital jets.
Yeah, who's this?
I'm Dr. Hershey.
Hello, Doctor. Okay, excellent. So you know, the short PR interval, you know, this is short. This is short, right? This is short, but this is not physiologically short. It's not impossible. And then at times, the P starts after the QRS, right? P starts after the QRS, P starts after the QRS, right? So that short PR is not, in fact, a P AV node QRS conduction. It's more the sinus node came in and the AV node depolarization starts just after the sinus depolarization started, okay? So there's no communication between them. Rather, they just happen to be on time with each other, simultaneous with each other, okay? And then eventually, the AV node AV node conduction is even faster than your sinus conduction because again, the QRS starts before the P waves, okay? And then when the QRS activation slows down, then you get the P wave that might conduct downward like this patient, like this QRS maybe, but definitely like this QRS, you know, at some point, the P comes in and the AV node comes in on at a time where the AV node is happily accepting it. And then once it accepts it, you get an R wave that is often earlier than your usual or during your rhythm strip, okay? This is called what? There's a name for that beat. Sinus capture beat, okay? So when you see AV dissociation, and so this is called AV dissociation where the P's and QRs are not related, at least in some part of that ECG, okay? And at some point a P conducts down the AV node with the usual, with your typical QRS complex, although there is slight aberrancy here, but that P definitely went down the AV node and conducted such, and that's why your R interval, the RR interval here became shorter than your rest of your rhythm strip, okay? So this is called, so this patient has, you know, congenital, at some point, you know, was faster junctional rhythm, but now on drugs, he has accelerated junctional rhythm. Again, because there is AV dissociation, there is the P wave is sinus looking P waves, again, because it's positive in lead 1, positive in lead 2, positive in lead 3, and so forth, and positive in AVF. The QRS is identical during conduction, like here, and during tachycardia. So there is identical sinus and tachycardia QRS. Okay, so that's an example of accelerated junctional rhythm / congenital jet. Okay, it's a form of focal tachycardia that is irregular, like you see here. Okay, so I'm now showing examples of focal tachycardias. Okay, okay, so the capture beat, like we said, it's a beat. It's a conduction. It's defined as a conduction of an atrial impulse to the ventricles when the predominant rhythm is originating from your AV node or the ventricles, like some rhythm outside the atria. Okay, so the P wave temporarily captures your ventricles, shortening the RR interval as such. Okay, and you know, occurs during AV dissociation. Okay, guys. Okay, so when you see AV dissociation like this ECG, what is your differential?
Heart block.
Complete heart block.
Hello. What else?
Junctional tachycardia.
Yes, excellent. So you have, you know, complete heart block, your typical AV dissociation example, and then you might have accelerated junctional rhythm or accelerated ventricular rhythm or junctional tachycardia, ventricular tachycardia with AV dissociation. You know, AV dissociation only happens when the tachycardia doesn't, your ventricle or your AV node tachycardia doesn't conduct retrograde, so that it doesn't associate with the atria. So you have a focus in the AV node, but there is a retrograde block and the sinus node just fires regularly. So you have dissociation between them, okay? Or if you have sinus bradycardia with junctional escape, ventricular escape, you also will have AV dissociation. So when you have AV dissociation, you have to ask yourself, is the patient bradycardic or tachycardic, the QRS? If the QRS tachycardia with AV dissociation, then you think accelerated junctional rhythm, jet, or VT, or accelerated ventricular rhythm. If the patient is bradycardia, then you think, is he in heart block or is he just in sinus bradycardia? Okay, guys. So some people call me and they just describe the ECG as AV dissociation. This it's not, you know, a diagnosis. You have to say what type of AV dissociation from these three differential. Okay, guys. Okay, that's a difficult one. This is a patient that we have, just actively in our ICU. This is an atrial wire study that was just done 2 days ago. So it's a TET who is very sick, post-operative, post-operative TET that is sick. I'll just help you here because atrial wire studies are difficult and people are not used to them. So, when you see, so I first of all, I'm telling you it's an atrial wire study. Okay, so I have to tell you. Otherwise it might be difficult to decipher, but the atrial wire P waves, you will not see P waves, you'll see atrial EGMs, okay, or electrical activity from the atrial tissue itself, not through the skin. Okay, so that's why you see sharp deflections that are representing the action potential of the atrial tissue where the atrial wires are placed. Okay, anyways, so you see you see a nice QRS T wave here. Let me erase my my note here. Okay, so you see a QRS followed by T wave, so that's your QRS. Okay, that's because there's a T following that complex, so that's your QRS. Okay, so this is how you figure it out. So that's your QRS here. Okay, QRS here, another 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 QRS here, and so forth. Okay, guys, agree? And then you see the other stuff would be your atrial electrical activity, which is these guys, the sharp ones. This, and then this. There's one hidden in the QRS, and here, and so forth. Okay. So long story short, this is a patient who has AV dissociation, meaning there's no relationship between the A's and the V's, but he's in tachycardia. So it's accelerated junction rhythm. In his case, the junction rhythm is wide because he has right bundle following the tetralogy repair. Okay, guys? And he's having this because he's sick post-op. He has many issues, sepsis and right-sided heart failure and stuff. Okay. Okay. Questions? It's a difficult ECG, so that's why I'm rushing through it. And we have many ECGs to look at. Okay, so that's post-operative AV dissociation, acceleration junction rhythm. Questions, guys? Proceed. Yeah. Okay. Okay. What strikes you in this ECG really quick? It's a newborn, very fast. What do you see in this ECG really quick? Narrow complex, irregular, right? What else strikes you in this ECG? دكتورة منال, أي واحد, really quick. Just one word, typical.
Multifocal B wave.
Multifocal P wave. Okay. So this is your P wave, صح?
Morphological, different morphology of B wave.
Okay, this is your P wave, صح? They look different because sometimes they are hidden within the QRS. Okay. So you have to be careful. So I don't, they look different just because of QRS and T waves. Okay.
Looking ventricle more than atrial.
Yes, excellent. So there's more faster V's than A's. Okay, so there is more V's than A's. Okay, what else? So what else that strikes you? More V's than A's, but narrow QRS.
Yes, narrow QRS.
Sorry.
Yes, narrow QRS.
Yeah. So what's your diagnosis here?
It's because tachycardia, congenital jet.
Excellent. It's another jet example. I'm showing you so much jet today because it's a common ECG, and you have to just it's easy ECG. You see AV dissociation, you see sinus P waves with AV dissociation, irregular and narrow complex tachycardia. That's it. Okay. Okay, guys. So there is AV dissociation, meaning there is no relationship between the A's and the V's. So you see here A on top of the QRS, A just before the QRS, A after the QRS, right? So there's no association. And the A's to A, they usually would march out, okay? They will be on time, okay? A's to A's. And the QRS's though, you might see it's irregular because those the QRS that comes in early, this guy, for example, this is probably a sinus capture beat, okay? And then it pauses a little bit, and then you get QRS, tachycardia QRS, because this is where it's originating from, okay? And so forth, okay? So it's irregular because of the sinus capture beat or because of the nature of the tachycardia that is focal, okay? Okay, guys? So if you see sinus capture beats, you see AV dissociation, you see narrow complex tachycardia, that's jet. That's your typical jet until proven otherwise, okay? Okay, so that everyone knows this, not everyone, but somebody especially knows this patient. It's a difficult congenital jet baby that we have.
Yeah.
Okay. Yeah, yeah.
طب
So
دكتور محمد معلش
yeah.
ازاي افرقها عن المالتي فوكال اتريال
Well, the
tachycardia؟
P-waves, there's only one focus P-waves. Why do you say multifocal? Yeah, in multifocal you
أنا
have
حاسس
you need
إن
at
في-
least 3 P-waves, different P-waves, at least. Where is your 3 different P-waves? ما في 3 P. There's only one P-wave.
مم.
Okay.
بس الامبليتيود بتاعها مختلف.
Yeah, because remember, there's a T, that P wave might sit on a T, might sit on a QRS. So of course it might change, but you have to, your mind should adjust for the QRS and T wave superimposed QRS and T waves.
Yes.
Okay. Okay, so when you have jet, could be like we said, post-op or congenital. And then ECG findings, you will have VA dissociation, like with sinus capture beats. But you might have one-to-one retrograde P. So, your AV node is going fast, but it engages the atria retrograde. So you'll have, it's like an SVT. So you'll get one-to-one conduction with short RP. So you might see one-to-one conduction, like for example, this ECG, that is exactly the same patient, this patient and this patient the same. But, here, there was retrograde VA block such that there is AV dissociation. Here, there is retrograde one-to-one conduction, and you don't see, you see, it's like short RP SVT. So if you see this ECG, I'll tell you it's an SVT, just give adenosine. If you give adenosine, if it terminates, that's your SVT. If it didn't terminate, and then you document VA dissociation during adenosine, then that's congenital jet. Okay? ولا هذا confusing؟ يعني again, so if you have a focus here, okay, okay, if the focus engages the atria retrograde, you will see one-to-one tachycardia, okay? You will see tachycardia with short RP, like an SVT, okay? But if there is VA block, you will get VA dissociated because the sinus node will, fire, normally because it's a pacemaker cell, okay? Okay, guys?
Okay.
Okay. And sometimes this is complex and I will not bother you with this. Sometimes there is retrograde VA wonky back. It's like your AV node wonky back, but there is retrograde wonky back. So you PR prolongs, and then blocks, like in this example. So, there is no P wave. This is atrial wire. So, QRSA gradually prolongs until it blocks here, and then so forth. But I will not bother you with this, rare. Okay, so reentrant or automatic, like we said, reentry is sudden onset, sudden termination, regular. Automatic, there is irregularity into it, usually starts slower and then speeds up, bursty, and so forth. It's difficult to treat. Sometimes patient might present with tachycardia-induced cardiomyopathy like the PGRT, okay? So for example, this patient had atrial tachycardia, very bad function, after ablation, function recovered, and there was a focus by, so this is the pulmonary veins. So this is a different 3D mapping system, looks a little bit different. So that's your pulmonary veins, that's your atrial appendage, this is your left atrium, and there's a focus between your left pulmonary veins and your left atrial appendage, okay? This was where the tachycardia was coming from, okay? Okay, so one more thing that you have to pay attention to is your telemetry, okay? So that's, that's why I always ask my patients to be on a telemetry bed so that we review this. So for example, there was an SVT patient that it was very difficult to treat just 3-4 weeks ago. You guys probably remember her, sorry. So anyways, she does this, sinus rhythm, suddenly goes fast, largely regular, and then suddenly terminates, okay? So that's an example of a re-entry, right? Not focal, but re-entry. Am I correct? So re-entry starts suddenly, terminates suddenly, and it's regular during the tachycardia, okay? So when you see this telemetry, without even looking at the ECG, it's probably a re-entrant, if it's narrow complex SVT, okay? If you see a telemetry that goes slightly up, patient is crying or having fever, it goes slightly up and then fever subsides, slightly come down, that's sinus tachycardia, okay? If you have a telemetry that the patient goes suddenly quick, or not suddenly, gradually, relatively gradually quick, but then alternates so much and then, terminates and then again goes back up and then varies so much and then terminates, so forth. This is a focal mechanism. If you have a telemetry that there is only one straight line, never changes while the patient is asleep, while the patient is awake, then the patient is a post-op. What might you suspect? Quick question here. Do we have ICU people here? We don't, probably. Okay, so if post-op patient whose heart rate never changes, what do you guys think of? Paced rhythm, right? The ICU is pacing him at a specific heart rate. Am I correct? Okay.
Yes.
If you have a patient who, if the SVT is 150 or the re-entry tachycardia is 150 versus 200, of course, the 150 is slower, so you might think, is he in 2-to-1 conduction, like flutter? That's why the tachycardia is 150, versus if it's 200, then you think it's more likely SVT. Anyway, so telemetry is very important, okay? If you have a Fontan patient who's always tachycardic, but a little bit tachycardic, but always tachycardic, like 130, 120, then it's probably not sinus tachycardia, it's probably something else. There's no variability and always a little bit fast. So you have to think of slow intra-atrial re-entry tachycardia, which they are predisposed to. Okay, guys. So it's an hour already, so I'm trying to finish relatively on time. So again, now you have a patient who is in narrow complex tachycardia, and you want to give adenosine. Which tachycardia is most likely to respond to adenosine out of these guys? Easy question. So AVRT.
The most common AVR.
So AVRT would terminate. What about
Yes.
flutter, intra-atrial tachycardia? Would it or would it not?
No.
No. صح. AVNRT, would it terminate?
Yes.
Yes. Automatic terminate?
No.
No.
Most likely no. Okay. So if you have adenosine, it works best for AVRT and AVNRT. Otherwise, it will not. It might be helpful in diagnosing flutter, might be helpful in diagnosing atrial tachycardia. That's why we use it sometimes, not to terminate tachycardia, but to document the type of tachycardia. There's a difference, okay? Sometimes we know it's flutter, but to make sure it's flutter, we give adenosine to see the flutter waves, okay, guys? Okay, but I mean, adenosine is still a drug, so you have to, use it carefully and, smartly, okay? Okay, there are rare atrial tachycardia that foci that might respond to adenosine, but usually it goes back into tachycardia after adenosine fades away. Okay, so rapid, if you have a post-op patient with atrial wires and you have tachycardia, which tachycardia might be responsive to rapid atrial pacing out of these? It's a more difficult question.
Rapid pacing, overdrive.
Well, when I say rapid pacing, I meant super fast, not just overdriving it. So meaning,
Jet and atrial tachycardia.
Yeah, so if you pace slightly faster than jet and atrial tachycardia, you will overdrive them. بمعنى, you will just pace faster, and so that you suppress the focus. But once you terminate the pacing, the focus would come right back. Okay, so with rapid atrial pacing, if you terminate the tachycardia, meaning it doesn't come back, which one might terminate and doesn't come back with rapid atrial pacing?
Oh,
Is your what? AVRT, would it respond to rapid atrial pacing? Yes or no?
yes.
Yes. Atrial flutter? Yes.
Let's not choose
Terminate.
yes.
Its re-entry terminates with rapid atrial pacing. Okay. Okay, guys. So
Okay.
with flutter, because it circulates around the tricuspid valve, if you pace really fast, faster than your flutter rate, not your QRS rate, it will collide with the re-entry circuit and it will terminates it. Okay. So with if atrial flutter, with AVRT, with AVNRT, rapid atrial pacing would terminate those tachycardias. Okay. For automatic tachycardias, you will just overdrive them. Bimana, you will just control them. You will, they will just be underneath. Once you stop the pacing, they will come right back. Okay.
Okay.
Okay, guys. So you'll overdrive the tachycardia or tachycardia, but you will terminate AVRT, flutter, and AVNRT. Okay. Okay.
But what is the point of overdrive?
Well, because jet, for example, if you have a jet at a heart rate of 140, okay, you know, with jet, there is AV dissociation, there is AV dysynchrony, right? There is no AV synchrony, right? So when you rapid it, when you overdrive it, you go a little bit faster, you have AV, and then hopefully the cardiac output might improve, okay? Especially if the patient is conducting conducting. So A, pacing, and then QRS, normal QRS conduction, okay? Then your cardiac output might improve.
And for the ectopic tachycardia, atrial tachycardia.
Yeah, if it's 1-to-1, if it's 1-to-1 at 140, you know, or 130, and the patient is a baby, then, you know, there's no point of overdriving it because it's 1-to-1. Hemodynamics would be the same. You have to just treat it medically or do something with it, you know. So, but for jet, it's nice because you want to improve hemodynamics for jet. Okay? If it's, you know, if you have a rapid atrial tachycardia, but 1-to-1, for example, let's say he's at 180 or 190 and he's conducting 1-to-1. If you pace fast such that the AV node blocks, you might have eventually slower heart rate because you're pacing fast, so you're controlling the tachycardia, but you're pacing fast enough so that the AV node doesn't conduct 1-to-1. So you might, in fact, even improve the patient just by, you know, you see, so you're blocking the tachycardia, and you're inducing AV block so that the heart rate eventually is slower. Okay, this is how it's helpful.
Yeah. Okay.
Okay. So when you, so when you want to shock the patient, the patient would improve for AVRT, for flutter, for AVNRT, but for automatic tachycardia, it will temporarily improve the patient, but then they will. So that's why we don't shock jets. Okay, that's why we don't shock atrial tachycardia. Okay, and so you remember we have a patient who had atrial tachycardia. Remember when we went to the, you know, and it looked very flutter. We shocked him. It didn't terminate. So then this is a hint that it was not flutter. It was atrial tachycardia. Okay, and then when we reviewed the ECG very closely, there was irregularity into it. So that's against atrial flutter. Okay. Okay. Anyways, so okay. So I'll move. We're almost done. Okay. So that's another halter of our patients, and I will just give you the answers because we are out of time, and it's a little bit complex. So PQRS, okay, you know, this is the previous T, not very well shown here, and that's the subsequent T. It looks different, right? So, right, you agree, right? It looks more peaked, right? So then you wonder whether there's a P hidden here. That's why it's peaked. So assuming there's a P that is hidden here, so the patient had a PAC, long PR, and then went into fast tachycardia, okay? Initially wide, and then narrow, right? So when you have wide and then narrow tachycardia, then you have, you have to think, so you have to think, we have two differentials. Is it what, guys? Could it be VT? If you want to say this is VT, then you have to say this is a patient had a VT and then SVT, right? You cannot have only VT that goes into normal or usual QRS, right? So VT is very unlikely in this case, okay? Sometimes you have combined tachycardias, but you know, this is not in pediatrics, very, very unusual. So then what do you think of if the tachycardia starts wide and then narrows down? What is the term for that? Easy.
Apparently,
Aberrancy. Yes.
Regression.
Right. So if you have a wide QRS, onset, usually it's at the onset of the tachycardia, it's wide and then narrows down. So this is called SVT with aberrancy. Okay. So you have an aberrant conduction initially because the bundles are not ready for fast conduction. They were used to specific heart rate, and suddenly there's a fast heart rhythm. There will be slowing or fatigue in the bundles until they get used to it. Okay. So this is very well known, and it's called Ashman's phenomenon. So anyway, so there is a wide QRS at the onset of the tachycardia and then narrows down. Okay. Anyway, so that's suggestive of an SVT, and starts with the PAC. And then if you look super carefully during the wide complex, the tachycardia might be slightly slower than during the narrow complex. You know, it's ever so slightly slower. So then this is another hint that the QRS is part of the tachycardia, right? So if the tachycardia slows down when the QRS is wide and then speeds up when the QRS is narrow, you know the QRS has something to do within the tachycardia circuit. Makes sense, right, guys? صح?
yeah, yes.
Okay. So that's another hint. There is, it's not, AV node reentry, for example, it's more AVRT, right? There is the V is part of the tachycardia, not just the AV node. Okay. So, plus the RP, is it long RP or short RP in this case, guys? What do you guys think? That's the term that you need to get used to looking at. Difficult to tell maybe, but again,
Long RP.
yeah, yes, excellent. So this is your T wave, and then you see something within that T wave, right? There's something here. If you look at if you see the P wave very clearly and with some distance after the QRS, that's longish RP or long RP tachycardia. Okay. So, so that's an example of a patient, it's a reentry because it's very regular, sudden onset, sudden offset, right? So it's a reentrant SVT, starts with a PAC, it's orthodromic because it narrows down, it's a usual complex. There is shortish RP, not super short, shortish meaning not short RP, okay? But not by definition long RP, it's shortish RP, in between, okay? And then it might be slightly slower down during bundle branch block, wide into narrow. So that's so that's an AVRT type SVT, okay? When I say it terminates with a P wave and AT unlikely, because if you have it, so there's the P wave, the termination is with a P wave, right? So meaning the termination is in the AV node level, right? So P, AV node block, and then no tachycardia, right? If it's an atrial tachycardia, it has nothing to do with the AV node. So when you see termination of tachycardia with a P wave, atrial tachycardia would be unlikely because this tells you that the AV node might be very well part of the circuit. Makes sense, guys? صح?
Yes.
Agree?
Yes.
Okay, agree. Yani again, if the tachycardia blocks in the AV node, meaning there is a P and then termination tachycardia, then it's unlikely for it to be atrial tachycardia because atrial tachycardia has nothing to do with the AV node. Okay? Okay. And this patient, in fact, had an ablation as well. And he had indeed AVRT. There was an accessory pathway just by the CS. Okay. He was 6 years old at the time. Okay. Anyways, he had so much SVT during his Holter. So he was a very strange patient, meaning he had so much SVT during his Holter, but he wasn't largely symptomatic. Anyways, so this is not our patients from the net. So if you see narrow complex tachycardia, you always ask yourself, so it's fast, narrow complex tachycardia, it's SVT. Okay, then what type of SVT? To figure it out, you want to ask yourself, is it long RP or short RP? Here, you don't see clear P waves. So then it's, then it's more likely short RP, right? You zoom in V1 or you look at V1 because V1 is a good lead to look at for P waves. you see there's this bump at the end of the QRS. You wonder whether it's a P wave or is it just part of the QRS. You don't know. Anyways, you want to give adenosine because you want to terminate the tachycardia because it's most likely SVT with AV node involvement. You give adenosine, indeed to stop, and then you look at the V1 back into the V1. You look at the V1, you see the hump that was here went away, right? So then retrospectively, you know that hump in that QRS was P wave. So then indeed the patient had short RP SVT. Okay, guys? Okay. Okay. So onset is important to figure out whether, you know, reentry or focal. And then if it's a PAC onset, then it's more SVT rather than if it's a PVC that starts with tachycardia, then it might be less likely it's an SVT. Okay. Terminates again, like we said, if it terminates with an with a P, then atrial tachycardia would be unlikely. Okay. If it terminates with the QRS, then it might not help you so much. Okay. So that's another example that this was a teenager. She was like 21 years old. She was just in the EP lab like 2 days ago. And she had so much SVT since, you know, when she was a pediatric, and her atria is huge and she has cardiomyopathy. And then this is her tachycardia, you know, long RP clearly, right? Right, guys?
Yes.
Yes, long RP. So that's the T wave. And you know there is something after the T wave here. So slowish tachycardia with long RP. So you have differential, but terminates with the P wave. So then atrial tachycardia was one of your differential and then went away, right? This was happening repeatedly. Okay. So you know it's a PGRT, probably type SVT that was very incessant and caused cardiomyopathy, right, guys?
Yes.
Okay. Okay, you know, easy ECG. What is this? Baby. This was a baby with what?
Flutter هذا.
Flutter. Excellent. Okay, baby with flutter. You know, flutter waves. More P's than QRSs. Narrow complex tachycardia. Okay, so that's, you know, when you have more P's than QRSs, it's atrial tachycardia or flutter. Okay, if it's very regular and sawtooth appearance, that's flutter. If it's irregular and not sawtooth appearance, it might be more atrial tachycardias. Okay, atrial tachycardia. If you have P's equals QRSs, not very helpful to distinguish what type. If you have QRS more than P with the usual or narrow complex tachycardia, then it could be jet, right? Could be very well jet, or rarely AVNRT, but I will not go into this. Okay, but think of jet for you. Okay, okay. So that's why figuring out the P-QRS ratio is important to figure out whether it's atrial tachycardia or whether it's jet. Okay. Okay. So P wave access during SVT. We already discussed this. If you have, this is our patient. No, this is a different patient. So this is a patient who is in tachycardia and non-sinus, right? P wave is negative in lead 1, right? Right? P wave negative in lead AVL. So it's non-sinus tachycardia, but the axis is, you know, going from top to bottom, right?
Oh.
Right? And then from, you know, top to bottom and then left to right. Okay, so it's actually this way. Okay, so that P wave axis is not suggestive of AVRT, right? AVRT typically the axis would be, you know, more superior, not inferior. Okay, typically. Okay, صح?
Yes.
That's your, it's another baby with a long RP tachycardia. Again, the axis is inferior. So that's more typical of AVRT, okay? Of course, you might have atrial tachycardias that with a superior axis or inferior axis, sorry. But if you have, you know, the axis just might help you figure out which one is more likely, okay? So if you have a superior axis, you know, often it's AVRT or inferior atrial tachycardia. If you have an inferior axis, very often it's an atrial tachycardia. Okay. Okay. You know, another halter again starts with wide complex, goes narrows down during tachycardia. So it's very similar to that previous halter. Okay, very similar. So wide complex tachycardia narrows down, so it's an SVT. And terminates with a P wave. with long RP tachycardia, right? Easy. Am I correct?
Yes.
صح? Okay. So AVRT. Okay. So if you pay attention, you know, RP is almost always fixed. If you measure, the RP is very fixed. And then if the RP is very fixed, meaning there is probably a RP relationship. So there is an accessory pathway between them. For atrial tachycardia, the RP is very often variable because they have nothing to do with each other. Okay. Okay. So and then during the wide QRS, the tachycardia was slower, and then it sped up with narrow QRS. So that's a hint that the bundles are part of the tachycardia. Okay. So fixed RP, cycle length changes with aberrancy, so the V is in the circuit, terminate with the P wave. So it's also just a VRT type SVT. Okay. Okay. Okay, so one last thing, you know, this is a little bit more difficult, so let me, I guess, pay attention to RP. Okay, we have already mentioned this. Sometimes, you know, if PP drives the RR, this might be suggestive of atrial tachycardia. This is more difficult to figure out during an ECG. So this is another last ECG, I promise you. Okay, so that's actually just, I got this ECG from a friend in Canada. Okay, so they were wondering, what did I think? So it's a 7-month-old who had seizures, I believe, or, you know, possible seizures. And then in the ER, this was his, you know, ECG. You know, obviously a little bit fast, and he was, you know, he was not doing much. He was sleepy or being fed. So unexplained tachycardia. Okay. So they, you know, so you wonder, is he, you know, of course your differential would be, it's a long RP tachycardia, right?
Long.
Long RP, صح? The sinus tachycardia is your main, you know, one of your main differentials. So the question was, for me, is he sinus tachycardia or is he something else? So what is here? What can you see here that is very unusual for sinus tachycardia? Anything?
The B on top of T.
Yeah, but يعني, so what I'm trying to say is the PR interval is long, right? If you are in sinus tachycardia, you are, you know, you are alert, you are active, you are.
First degree heart block.
Yeah, the PR typically shortens during sinus tachycardia, and you are sick. Your AV node is alert, is hyperactive. Okay, so during sinus tachycardia, typically your PR is not very long; it's usually short. Okay, unless the patient has AV node disease on top of sinus tachycardia, which is, you know, this baby has, you know, should not have an AV node disease. You know, he's otherwise a normal baby. Okay, so when you see, you know, a long RP with PR that is long, sinus tachycardia is not in your first differential because unless you have an AV node disease. Okay, so this patient, I told them, you know, yes, it might look like sinus P because it's positive in lead 1, positive in lead 2, positive in lead 3, positive in AVF, right? It's a little bit flat in lead AVL, which may or may not be suggestive of a sinus P wave. But what's strange is, why does he have first degree AV block for a baby? Okay, so and when they gave adenosine, you know, if it's reentry, then it should stop and then not come back. But in his case, his the PP, you know, the atrial rate continued. Yes, it's slightly slowed down because there are atrial tachycardias that are responsive to adenosine, like we said. But the P wave didn't really change. You know, that P wave is very identical to the tachycardia P wave. And if you look at all leads, okay, so. No, not AF. AF, you will not see well-formed P waves in AF. AF, it's throughout, no well-formed P waves, no well-formed atrial activity. Okay, so then you know, so then, you know, they gave her beta blocker because the assumption was it's an atrial tachycardia of some sort, and then indeed. Well, flutter, you know, it's not very fast for flutter. Flutter is usually fast. The P to P interval is fast. In this case, it's just 180. Okay, so So they started beta blockers, and then they told me after 1 or 2 hours, roughly, suddenly the heart rate, normalized with a slightly different P wave, but definitely the PR normalized, and there was sudden, heart rate change. Okay. I don't have the she did not, send me the ECG for when the patient was in sinus, but at least clinically, the patient probably indeed had a tachycardia that terminated with beta blocker, and the PR just normalized. Okay, as expected with sinus rhythm. Okay. So in summary, we had discussed all these points. Pay attention to the QRS axis during tachycardia. If it's typical right bundle or typical left bundle, it's more aberrant conduction rather than VT. And that's it. Any questions? And people are largely quiet. Either they are so confused, or they're so clear. Confused or clear?
Oh, clear. It's okay.
We had mentioned a couple of those points before, so that's why I was a little bit fast. Plus the time, I have to be fast. I cannot speak forever. But please ask questions if you have a question. Okay, any questions before we quit? So now hopefully SVT, at least almost everyone knows whether the patient is in SVT or not. But the next step would be what type of SVT. Okay, that's hopefully we already achieved that. We will identify a patient is an SVT or not based on many lectures that we discussed SVT so much. Okay, so number one goal is to figure out the patient is SVT or not. Once he's in SVT, then your next question would be what type of SVT. Is he in flutter? Is he in AVNRT? Is he in AVRT? Is he PGRT? Is he Maheim? Is he, so forth. Okay. Of course, it might be difficult, but with these tricks, might help you clarify the type of SVT, and then you would know the prognosis. You would know when to attempt to ablate. You know what to tell the family in terms of ablation success and so forth. Okay. Okay.
شكرا جزيلا.
Okay. Thank you, guys.
يعطيك العافية.
شباب السعودية clear? It was clear؟
كثير يعطيك العافية. شكرا.
الله مع السلامة.